restorative dentist and orthodontist and had the crown placed. And this is JN after 5 months of healing after the implant placement right in the middle where we wanted it, and this is a 1.5 years post-implant placement, everything nice and stable. So now I'm going to move on to fully guided implant cases using the CBCT scan and intraoral scanners using the Biomed Free Eye Navigator system. So this is a complete digital flow. This is the nice navigator system for the tapered implants. It's a nicely compact kit, has all the parts and needle and the sleeves, and underneath has all the implant mounts for multiple implants, different sizes, different implant platforms, and also a tapered kit. I'm gonna review the case of Richard. This was, again, one of our hygiene patients, had a perio-endophthalmic tooth number 30 on an otherwise healthy mouth, quite a complex occlusion in his case. As well, you can see everything is quite flat. Anyway, the implant number, the tooth number 30 had a 10 to 12 millimeter pocket with forcation involvement, so we decided it was time to remove it. And this is how it looked clinically after the extraction, a traumatic extraction, quite a significant bone, buccal bone dehiscency, quite nice lingual bone. We're able to use the same cocktail of bone allograft, growth factor, and resorbable membrane and obtain a complete closure. This is how Richard unfortunately decided not to have the implant right away, so this is about a 1.5 years after the bone grafting. He decided to have his implant. We took a combi CT scan and a surface scan to see what we have to work with. Obviously, the bone, like anywhere else in the body, in the mouth, the same thing. If it's not exercised with either loaded implant or a tooth, the bone does shrink. And when I was looking at his case, I thought he had quite some buccal resorption already, and I wasn't sure I'm going to be able to place the implant freehand without additional bone grafting. But we decided to use the navigator system, so we merged. These are a few other, we took the scan of the arch and interest, of the opposing arch as well as the bite, and we merged the two files, the STL and the DICOM files from the Combeam CT scan, and I'm currently using the 3D diagnostics in Boston to help us for now we're playing together the case, but also help me with printing the surgical templates. We put the virtual crown in the desired position, and then we decided where the implant position would be. As you can appreciate, actually there is plenty of bone weight, so no need to do any additional bone grafting, but that's the beauty of being able to have all the information into a computer, so you can actually analyze all this data. Again, this is the soft tissue and the tooth in transverse section. This is sagittal view, make sure it's in middle of the ridge as well. And in this case, we decided he had a buccal concavity, but longer, so we decided a 10 millimeter long implant was plenty. The nerve in his case was quite far away, so that wasn't going to be a complicating factor for his case. Most of my cases, every time I am using actually and probably you may have noticed in all my cases so far, I'm using a platform switch. I have been very successful with preserving all that bone that we are actually building, and we're going to see a few follow-up cases. The bone does stay there if we are able to medialize that implant abutment insertion. And based on the planning, this is the design of the surgical template. Again, a tooth-borne surgical template with inspection windows to be able to me around here, as well as my assistant is going to be able to help making sure that the template is seated. This is how the printed surgical template, the free eye, looks like, with the sleeve in the precise position. And this is at the time of the surgery. So this is the surgical template inserted. We're getting a drilling protocol. Obviously, every on a case by case, Dr. Martin was very nice and helpful, making sure that all the steps we evaluated the cases together. And We came to the surgery date and we placed the implant in the position that we wanted. Because he had enough keratinized gingiva, we decided the implant was nice and stable. We decided to do a one stage. So I was trying to place and seat the end-coat abutment. Obviously, we had an idea from the planning phase that the bone is going to be, the implant is going to be somewhat subcrestal, and you're going to be having to remove a little bit of the bone to create the emergence profile, not only for the placement of the end-coat abutment, which I'm using most of the times, but also obviously to make sure that the abutment and the crowns are going to be well seated. As you know, this can create some complications early on. And we took a little bit of trial. I didn't want to remove too much bone around the just immediate placed implant, but eventually we seated it. And it's very, this can be a quite tedious step as well on its own, and it's very important to get it right. So we take the time to be doing it right. And in this case, because we had enough keratinized gingiva, it was a very minimal flap. So as I'm probably going to be gauging for my presentation, I very rarely remove keratinized gingiva. I'm trying to preserve as much of the keratinized gingiva because it takes quite extensive procedures to be able to build it back. And we are just doing a minimal flap incision, and we elevate so we can drill for the bone, preserving the keratinized gingiva. And this is Richard's case. This is immediately post-op, the implant to the end-coat abutment, and we'll talk about the end-coat abutment shortly. A nice keratinized gingiva on the buccal. This is the lingual. This is the site of anesthesia, and this is the implant in the final position. And I was able to take in limited view cone beam CT scan right after the implant placement on Richard's case. And this is the planning. And this is the execution, pretty close to where we want it to be, hopefully exactly in the same perfect position, both sagittal, transversal, and vertical positioning. This is Susan's case. She was contemplating this was number 13 for a while, has been back and forth with pocketing, developing quite an infrabony defect, and had started to become mobile. She had orthodontic prior, and she had one of the bicuspids removed, and that the asthma was never closed. So maybe that's one of the contributing factors. Obviously, some occlusal trauma involved. So we decided to extract it number 13. We had an Essex fabricated obviously prior. We extracted to number 13, grafted the site. In this case, I didn't want to mobilize too much of the buccal. The tissue already quite deficient with frenum pull, so I did a pedicle connective tissue graft from the palatal, since we have the palate available with plenty of keratinized gingiva, keratinized tissue, and I was able to get complete closure. This is Susan's case. After 4 months of healing, this is site number 1213. In the coronal view, sagittal view, we can appreciate all this regenerated bone, again, good density. And in her case, she decided to use guided planning and hopefully placement as well, because we wanted the implant to be exactly in the position where it was initially. So we took the intraoral scan along with the CT scan. We merged the two files. These are the intraoral scan, the occlusion and all the information that we need. And then we merged it. We overlapped it over the CT scan. This is the position of the crown, as close to ideal where we find where we want it to be. We can see the mesial cantilever there, trying to reproduce the position that she had initially. And in her case was somewhat challenging because, as you can see in all the transversal side, it looks like the implant is kind of short. It may be tempting to be placing a longer implant because you may be having some room to the sinus. However, when we took a coronal view of the CT scan, as we can move 360, we can look at it in all sides and angles. We're able to position the implant in such a way to miss or to engage the anterior wall of the maxillary sinus, and still at the same time come with the implant right in the middle of the crown for a nice, hopefully, school-retain restoration. This is her surgery. This is a surgical template in place. This is the free eye sleeve. This is the surgical protocol that, sometimes obviously you have to understand the bone, you have to understand the soft tissue, you have to know the protocol and feel the bone even through the guide to be able to adjust and make decisions intra-op. As it's not always as simple as just following 1, 2, 3, 4, 5 steps. This is during the surgery, and this is the final implant positioning. Again, this is the comb pure planned implant placement, and this is the immediate X-ray post-op. As you can see, where we planted, engaged in the anterior wall of the sinus. This is Beth. In her case, we ended up placing, we didn't have the digital intraoral scanner at that time, so we ended up doing a conventional implant placement. We removed tooth number 12 that was failing. We grafted the same protocol. We built a bone. This is a nice wide ridge. We used a radiographic / surgical stand to try to plan the position of the implant as close to ideal as possible. And this is at stage 2, right in the middle of the dentular space. And then in her case, as I mentioned, we didn't have the intraoral scanner initially, but we did have the intraoral scanner in the towards the restorative steps. So we ended up taking the impressions of the arch, maxillary arch of interest, and the encode abutment, opposing arch, as well as the bite, and we send the information to the lab, digital lab of preference for the restorative dentist. And this is the final implant restoration. She decided not to have tooth number 13, unfortunately, restored at the same time. So as I mentioned, I have been using a few implant systems. However, I have been very successful and happy with the Nanotype Search and Prevail platform switch. And lately, I have introduced, probably over a year ago, the teeth-free implant, who is quite a lot of design and a lot of research behind, has a contemporary hybrid surface with different surfaces at different levels to achieve different types of osseointegration, soft tissue healing, has a seal integrity and an integrated platform switching by providing a medialized implant abutment junction. I'm going to show some of my follow-up cases. These are number 29, 30, 31 at the time of implant placement. This is almost 3 years later. We can probably appreciate the bone is pretty much at the implant platform where we placed it. A patient is in a very rigorous 3 months alternating periodontal maintenance, also very important, like for the teeth, the implants as well, to try to make sure that we maintain these implants for as long as possible healthy. And this is the period test 4 months for post-osseointegration. This is the case of Margaret. She needed implant number 30 and 31. This is the time of implant placement, and this is almost 2 years later. Nice bone stability around the implant platform, and these are the final restorations. Splinted crowns. This is the case, I forgot her name, but she had multiple teeth missing posteriorly, and she wanted to replace them all. She wanted to keep her teeth and to replace the missing teeth with implants, so we ended up doing quite a few implants in her case. Number 2 and 3, we had to do simultaneously sinus augmentation, and this is the period test values -2, -3 around both implants. We had to do some bone lateral ridge augmentation on size 29, 30, 31, similar to what I presented, and very stable implants, -4, -6 stable implants. And on upper left, she did want every single tooth replaced with implants, so we were able to place 12, 13, 14, and 15. And this is about 2.5 years restoration on the right side, and about a year and a half since the implant restoration, so quite stable. And she's in a rigorous peri-maintenance. As I mentioned, I am using the Waterlace I+, mostly in managing the soft tissue. However, when we in stage 2, if we end up doing a 2-stage implant, and the Waterlace, it helps me not only remove the soft tissue and manipulate the soft tissue, but also helps me remove any minor bone around the implant platform. Many of the implants, due to the platform switches and good bones to begin with, they do heal with bone over the implant surface, so we have to go and trim some of that bone to make sure we completely see the healing abutment, the end coat abutment. And this Erbium Chromium YSGG laser is actually a safe laser around the implants. So the peri-implant soft tissue is of major importance in the upcoming prosthetic stages, since the gingival tissue attachment around the implant is one of the factors of success of implant rehabilitation. The advantage for laser treatment includes technical simplicity, kind of, absence for reduced postoperative pain and edema, as well as predictable results and complete tissue healing in several days. So faster healing, so we can get the patients back to you faster. There are multiple techniques to maintain or recreate calcinized gingiva facial to the lingual implants. You know, we do, as I mentioned, it's rare that I actually discard the calcinized gingiva. In this case, we used Cindy. We restored implant number 30 and 31, and at the time of uncovering, we did a mini flap with the laser, and we preserved some of calcinized gingiva on the buccal and some of the calcinized gingiva on the lingual of the implants, and we allow for the healing. And these are the final crowns with a nice wide vestibule and a nice calcinized gingiva band around the implant crowns. And these are the final implants on the X-ray. This is Victor. He had tooth number 10 failing endodontically, and he was in a rush to have the implant placed, so we took a pre-op scan. He had, not a very wide root tip and good bone, some buccal bone on the buccal, so we decided if we can to place an immediate implant. In his case, so we ended up removing the tooth number 10 and placing an implant at the same time. And this is at the second stage. However, we buried it, make sure it's going to heal. And this is his second stage with minimal laser procedure, preserving the calcinized gingiva. And this is the final restoration clinically as well as on the X-ray. Kathy. Also, we are using the laser on cases such as Kathy's when, I don't know exactly how this site started with, but obviously at this stage it has quite a significant mucogingival involvement. No calcinized gingiva, somehow this mucosa extends in between her implant, and despite an excellent home care that she has and a 3 months strict protocol of hygiene, there is no way, it's just very retentive for her to be able to, it's very retentive and very difficult for her and the hygienist to clean. So we were minimally in procedure with the laser. We were able to incise this mucosa, frenum, whatever it was, and we reposition it and let it heal there. And this is 4 weeks afterwards. Obviously we eliminated the very trappy frenum, and we created her a much better way and the hygienist to be able to keep the area clean, and thus hopefully increasing the long-term success of her implants. This is Bill. He had a similar case with probably some, I don't know how it started with, but obviously now it has a recession over the implant as well as a frenum pool. We decided to do it minimally invasive in his case and reposition the frenum. This is only, 3.5 weeks. He was heading to Florida, so I don't have a follow-up, a long-term follow-up, but sometimes it actually, or most of the times, it heals with a nice calcinized gingiva there as well without having to do more extensive surgical soft tissue procedures. This is Anne's case. She presented now on an already also integrated implant, but with recession. She had some probably mucogingival defect to begin with, as she had some pink acrylic or porcelain to begin with. However, the gum continued to recede and created and mucogingival involvement. So in her case, we decided to actually do a gingival graft to at the same time widen the vestibule, rebuild the keratinized gingiva, and hopefully be able to get some coverage. And nicely we're able to achieve all the goals. And this is 2.5 years after the gingival graft. This is a case of Allison, a young type 1 diabetic patient, fairly well controlled. She had, I don't remember exactly what happened to her in sizes 24 and 25, but she ended up having an implant with 2 crowns out of that. She was having now definitely some mucogingival involvement and some mucositis around it. We debrided her first to try to get this buccal tissue as healthy as possible before we decided to do a gingival graft in her case, again to widen the vestibule, create more room for the access of the the brush and all the cleaning devices during the hygiene, and we took her from there to here. This is a 7-week follow-up. So there is plenty of literature out there to kind of emphasize or justify the success and what we are doing. This is a brand new paper just published in iGEOMI in November-December issue on the accuracy of implant placement with a navigation system, a laboratory guide, and a freehand drilling. So it's a comparison, and the study's conclusion was that in comparison with the laboratory guide and freehand placement, the navigation system exhibited lower angular and axial errors. Despite its higher accuracy, the navigation system requires the operator to pay greater attention. And this is also a recent paper in International Journal of Computer Dentistry. It's an in vitro comparison of guided versus freehand implant placement, use of a new combined trio surface scanning implant studio, CBCT, and stereolithographic virtually planned and guided technique. And their conclusion is that implant angulation and apical displacement were significantly closer to the planned position in the guided group compared to the freehand group. Implant shoulder displacement, depth displacement, and direction of displacement did not differ between the groups. Within the in vitro environment, merged 3D surface scan data and 3D CBCT scan data can be used to plan and guide implant placement with greater accuracy than with the freehand technique. In a few cases, and I'm very close to the end, there are a few studies from 2016 and 17, patient-centered outcomes comparing digital and conventional implant impression procedures, a randomized crossover trial. Based on the findings of this investigation, both impression protocols work successfully for all study participants, capturing the 3D implant positions. However, the digital technique emerges as the most preferred one according to patient-centered outcomes and was more time-effective compared to conventional impressions. Another study on clinical fitting and adjustment time for implant-supported crowns, obviously the ultimate outcome and cleaning time for you. Crowns comparing digital and conventional workflows. The digital workflow was almost threefold more efficient than the established conventional pathway for fixed implant-supported crowns. Clinical fitting could be predictably achieved with no or minor adjustments with the digital process of intraoral scanner plus CAD/CAM technology. And the time efficiency in our study, difficulty and operators' preference comparing digital and conventional implant impressions, a randomized controlled trial. For single implant sites, the Quadrant-like intraoral scanner was more time efficient than the conventional full arch impression technique. In a phantom head simulating standardized optimal conditions, a high level of acceptance for intraoral scanners was observed among students and dentists. And my closing slide, just to review the treatment steps using the full digital workflow for implant treatment of partially edentulous patients. So if a patient has a tooth for teeth that are deemed non-restorable, refer them to us, please. I would prefer if we can take a shape to begin with, while my 3-shape scanner can take the shade I would like you to. I'm not proficient in that. we are doing a comprehensive evaluation of the FMX. We may take a cone beam CT scan and initial optical scan. If patient is periodontally healthy, once we have a kind of a temporization, if it's an aesthetic, highly aesthetical case, an Essex type of appliance is preferred for anterior cases. We extend the teeth, build up the bone. About 4 months later, we take a follow-up cone beam CT scan, an optical scan, and we begin the planning process, which we reviewed extensively. Computer-assisted, restoratively driven implant placement, when we are getting together to collaborate on agree on the final on the position of the implant crown, the virtual crown, as well as position of the implant. Printing of the surgical template, and I do verify the sitting in the patient's mouth. The guided implant surgery follows in one sitting, 1 or 2 stages, depending on the clinical and radiographic findings as we discussed. 3-4 months post-integration, we assess it with the perio test, and we do the stage 3 if necessary. If not, we'll probably try to get away from it as much as possible, given that we have as much information beforehand. Take digital impressions once the implant is also integrated in with the Trio scanner, and send the scans to the digital lab per your preference. And from then on, you take on to collaborate with the lab technician, the design and fabrication of the custom abutment and the crown using the CAD/CAM technology. And second time from sending the patient to us, when you're going to be seeing the patient, is going to be at the delivery of the abutment and the crown for the crown completion. And hopefully it's according to the studies that are saying that hopefully it should be 3 times, at least 3 times faster for you to be able to do it, given the precision of the digital scanner. Thank you very much for your time and for your attention, and please let me know if you have any questions before we move on to Dr. Martin.